Thank you, Chairman. I'm Shohei Omokawa from Nara, Japan. I'm going to talking about the management of hand and wrist osteoarthritis this morning. Okay, this is a 68 years female presenting this X-ray, and you can see the abutment syndrome of the ulnar. But and the CD indicated that and the widening of between the scaphoid and lunate, and also the incongruity between the lunate and the trochanter. And this patient have a radial ulnar malalignment and the carpal instability induced advanced OA. We can see the arthroscopy driving through sign from the radial carpal joint to the middle carpal joint. And they have a very advanced OA, synovitis. We can see the capitate, and from the radial to the ulnar, also the very advanced OA at the hamate. And also, again, we can moving back from the mid-carpal space to the radial carpal space, again to the ulnar head. And so it indicating the double drive-through sign between the SL and the LT complete tear. This is very devastating and osteoarthritis. This is another patient, and 85 years male, and indicating the DRUJ-OA, but there is no abutment syndrome. And so why the OA is here in the DRUJ? In the spinated CD, indicating widening between the radius and the ulnar. And so we did an open, and there is no TSCC ligament. So, and this patient have a DRUJ instability induced DRUJ-OA. And so mechanism of primary wrist OA is two. The first is joint instability, ligamentous. The second is malalignment, osseous. So the malalignment and the ligament dysfunction induced to the joint incongruity and leading to the osteoarthritis. There are two important causes of the primary wrist OA, malalignment and joint instability. So the treatment is, if the osteoarthritis is mild or moderate, we can do a correction osteotomy for malalignment. And so for instability, we can do a ligamentous reconstruction. And for advanced OA, we do a partial wrist fusion or reduction or without reduction, arthroplasty. So a classification of the wrist OA is divided into two, primary and secondary. And I'm going to talking about the primary wrist OA, 3, and then slack wrist and the SDT and the DRUJ-OA. Radial wrist osteoarthritis was reported 30 years ago by Dr. Kirk Watson and Dr. J.R. Rue. And they divided into 3, slack pattern, SDT pattern, and the combined pattern. This is the treatment option of the slack list. For the mild or moderate slack list, we can do a ligamentous reconstruction with a radial styloidectomy. For advanced OA, we do a four-corner fusion or proximal row carpectomy indicated in the slide. But I prefer the four-corner fusion because there is no incongruity between the lunate and radius. The primary proximal row carpectomy have an incongruity between the capitate and the radius. So this is a patient with slack list and Housemaker, the very weak grip strength and the very high DASH score. Using arthroscopy, we found that no cartilage at the scaphoid, but the proximal aspect, we can see the very healthy lunate cartilage. And so we did a arthroscopic scaphoid reduction associated with the four-corner fusion arthroscopically. And the dry arthroscopy, and put the bone graft into the metacarpal space and did a screw fixation for this patient. This is post-op X-ray, and at the 3 months, and the outcome and increased, and the movement of the forearm and the wrist is shown in this slide. So this is an isolated STT-OA, scaphotrapezial trapezoid osteoarthritis is shown. This is a very mysterious OA. Why the OA developed here isolatedly? No one can explain the exact clear reason. The HRD is not so clear, but this is a rather typical OA in the elderly female. And the HRD suspected was here, and the patient with STT-OA have a tendency with scaphoid extension, and also they may have a metacarpal instability because the STT joint is one part of the metacarpal joint. And treatment, surgical treatment of STT-OA is two parts. First is STT fusion, and the second is the STT resection arthroplasty. I do prefer the STT resection arthroplasty because STT fusion does not provide the movement of the metacarpal joint. It may be a problem for the patient because the metacarpal motion is a very important joint for that throwing motion of the human being. But too much resection, more than 3 millimeters, may lead to the suboptimal outcomes. And so we can see the X-ray pre-op, immediate post-op, and the 3 years post-op. And we can find the recurrence of the STT-OA because of the too much reduction at the STT joint. Okay, let's move on the DRUJ-OA. DRUJ-OA is the most common at the ulnar aspect of the wrist. It's due to advanced stage as class 2E and due to the Ulnocarpal abutment syndrome. And we can see the osteoarthritis at ulnocarpal joint and also the DRUJ. And so we found the ulnar variance is a significant risk factor of the DRUJ-OA. The treatment of the Ulnocarpal abutment syndrome is non-surgical and surgical. And if the non-surgical treatment fails, we do a surgery depending on the site of the osteoarthritis. If only osteoarthritis is limited to the ulnocarpal joint, we do ulnar shortening osteotomy and correction of malalignment or ulnar head resection, which is a wafer procedure. If the osteoarthritis is advanced to the DRUJ, we do a hemiresection arthroplasty, which is indicated in the slide in the left-hand side. Okay, and I'd like to talk shortly about the wafer procedure. The indication of the wafer procedure is the patient with ulnocarpal osteoarthritis only, no DRUJ-OA, and without DRUJ instability. And if the patient hopes to early return, we do this kind of procedure arthroscopically. This is a 46 years male tennis coach indicating an ulnocarpal abutment syndrome and the sclerotic change at the ulnar head. We did an arthroscope and the TLCC disc was torn and we debride the TLCC. Behind the TLCC, we can see the evaluation of the ulnar head. We reject the 2 millimeter of the ulnar head by the surgical burr. And we can see the TLCC ligament in the right below video. After the procedure, she can quickly return to the tennis coach. and the X-ray is shown here. And I'd like to talk about the hand OA. And there is a very common OA in the hand. And the first is shown in some CMC-OA, and very common in the postmenopausal women. And the quarter of the women with postmenopausal state have OA at this site. And the painful condition is about 30%. More commonly, we can see the DIP-OA, and very more common than the CMC-OA. The more than half female have this kind of site OA, but this site, it's very rare to have a surgical indication, but CMC is not. We usually do non-surgical treatment for this hand OA, and the brace is very effective. Also, internervous plane injection for the CMC joint is also a good choice. And the surgical indication for the DIP-OA is 3. First is very poor pain control. It is very rare. And the second is marked lateral deviation deformity. This is induced disability of the patient. We do a joint fusion for this kind of patient. And the third indication is intractable mucous cyst may lead to the infection. And so we do surgery for this kind of patient using skin flap and rotation on the transposition and advancement flap, depending on the size and the site of the mucous cyst. And for the Bouchard tubercle and of the PIP-OA, I do recommend surgery if disfiguring and then also painful. Resurfacing arthroplasty is very nicely indicated. And we have in Japan, there are 2 arthroplasty, cement type or cementless type from the propeller company in Japan, in Okayama. And so I'm now using the cementless type and resurfacing arthroplasty for this kind of patient. And lastly, I'd like to talk about the CMC-OA and the Eaton classification depending on the advancement of this OA. And we can see stage 1 to 2, 3, 4 advancing from mild to severe. And finally, we find in the right-hand side and the combined SCD and CMC-OA. But I'd like to say that TMC-OA does not provide all information because there is some discrepancy between the X-ray and arthroscopy. And even if the mild OA in this site, patient may have no cartilage, or half of the cartilage was gone, and so we should be careful about that. There are several surgical procedures for the CMC-OA, many kinds of arthritis and arthritic condition and based treatment. But I'd like to emphasize ideal treatment for advanced TMC-OA should provide both stability and mobility. This is a 46 years female, Eaton stage 3 OA, completely dislocation of some CMC joint and no cartilage and no movement due to the pain, severe pain. We did a surgery preserving the joint mobility and the arthroscopic trapezial hemireduction arthroscopy arthroplasty was done for this patient. And she recovered with both mobility and stability after the surgery. And I do provide a take-home message. First, non-surgical treatment is the gold standard for hand and wrist OA. The surgical procedure for hand and wrist OA is selected based on the disease mechanism and the degree of OA progression. DFB fusion is a standard surgery, and the resurfacing arthroplasty is recommended for PIP joint OA. Lastly, treatment of TMC-OA should be aimed to maintain both stability and the mobility of the thumb. Thank you for your attention.